My name is Jessie Higgins. I'm the Chief Mental Health Officer for the City of San Antonio, and I'm thrilled to bring this presentation to you today and to have gotten to work on planning this conference for each one of you over the last, pretty much since the last one ended. Last year we started working on this one. And I do want to encourage you to stay for the end of the day. We do have an excellent closing celebration. We do have the Alamo City Street Choir, a video from Mayor Ron Nirenberg, and Dr. Kara Allen from the Spurs, who is one of my personal heroes. And every time she talks, she gives me such energy and excitement. So I hope you will stay all the way till the end of the day. Today we are bringing you a session that we've titled Bexar County Jail Mental Health Services and an Innovative Approach to Competency Restoration. You're likely in here because you're got confused and went in the wrong room, or you care deeply about someone who has been touched by our criminal justice system. I want to remind you that all of us on this stage, especially these two wonderful, gorgeous, professional ladies, care deeply about people in our mental health, or people in our criminal justice system. This topic is difficult. The population is struggling, and the workforce is dealing with the cards and the situations that they've been given, and they're doing their very best. And so we do want to have time for questions at the end. Both of these presenters have their emails and their phone numbers and contact information that you will see in the slides. So if you don't get your questions answered, you will have a chance to email them and ask them for help or ask them for advice. Remember that even though you may have someone that you love who is in the criminal justice system in Bexar County, these presenters are bound by HIPAA, and so there's only so much that they can discuss with you, and there's only so much input that they can give you, but they can give you general advice and general knowledge of the services offered. And so all that to be said, we just hope that you come away with this presentation with concrete knowledge of what's going on in our county, how we're trying to work within the confines of our state's statutes and laws, and how much that we care for you and your loved ones and anyone that crosses that threshold into our criminal justice system. So let me go ahead and introduce our speakers. Our first speaker is Denise Descoteaux. She is with University Health. She's a licensed clinical social worker and chemical dependency counselor for 35 years with experience in the education and mental health fields. She has a specialized background in clinical social work and substance addiction and has been with University Health Detention Healthcare Services for the past 12 years. She is currently the Director of Mental Health Services at the Bexar County Adult Detention Center, coordinating services for over 1,200 individuals under psychiatric care and those found incompetent to stand trial. And after Denise, you'll hear from Annie Cortez. Annie Cortez is a clinical administrator at the Center for Healthcare Services and works for the specialty court programs. She was born and raised in South Texas to a proud Navy family and grew up on her grandparents' farm where she learned early about hard work. After high school, she was one of the first women in her family to attend college, and she has a Bachelor of Science degree in psychology with forensic emphasis from Sam Houston State University in Huntsville, Texas. She then returned home to San Antonio and completed her master's in counseling psychology at Our Lady of the Lake University and became the first woman in her family to complete a master's level in education. She began working for the Center for Healthcare Services in the specialty courts program in October of 2013 and completed her hours for her LPC and has continued to stay in that area and continued to work for CHCS in the specialty court programs. These are two talented and passionate individuals, and I ask you to give them a round of applause.
Good afternoon.
They don't do that, Denise.
They don't do that? Come on, house. Good afternoon. All right, yeah. Yeah. Right. So, as Jessie said, my name is Denise Descoteaux, and I'm the Director of Mental Health Services at the jail. I was asked to kind of give a brief synopsis of the services that we provide and how we identify folks with mental illness and provide treatment for them, or at least offer treatment for them within the facility. And then I'm going to segue over to Annie's presentation, which is a new program that has just gotten underway for a new kind of competency restoration that's being worked on. So did you know that 1 out of every 20 people in our country throughout their lifetime will end up in jail or prison? 1 out of 20. So not necessarily here, but if you look around the room, stay on the right side of the wall. If you look around the room, that is probably at least 6 of us. Everybody in here knows someone who's been behind the walls and how much of a stressor it is just to be arrested. Many who are caught in that net that is cast very wide to catch criminals have a mental illness. And many of you call for help to law enforcement when there is a mental health crisis and you want them taken to a hospital and they end up behind the doors, right? Not criminals. However, the longer they're in the jail around folks who may have a criminal mindset, the more exposed they are to that. The more vulnerable they are because they're already struggling with a mental illness or an addiction. So it's really important that we spend time looking at what can we do to keep them even from coming our way, right? And there's a lot of initiatives out there now where there are specialized trainings for officers to de-escalate, to identify mental illness, identify somebody with an intellectual disability, and divert them away from custody. Now, obviously, if there are violent offenses, somebody's been hurt badly, somebody's property has been damaged badly, something else has to happen, right? There's only so much that can be diverted. But how many of you attended Sally Unkefer and Judge Huff's presentation earlier this morning? So they had mentioned that we try very hard to divert folks away who have the minor offenses, right? So I'm going to talk a little bit about how that process works once they hit the doors over at the facility. One of the studies that came out, and I had to update this, I was wondering to know if it has increased since that time. So there are now 44 states in our country that are holding more mentally ill people behind their facility doors than there are in the state hospital systems and psychiatric hospitals. 44 states. It's estimated that there are more than 500,000 people with mental illness that are in county lockups in our country. It does not include state jail, state prison. It's just county lockups, local municipal holding areas that are detention centers. A report that came out last year from NAMI says that up to 44% of the adults that are incarcerated in our local systems may have a mental illness. I dare say that it might even be higher than that if we did the data today and had the background from what COVID did to us. This data probably was gathered before COVID and put out in a report that came out last year. When the state hospital system reduced their beds across the country reduced to 35,000. 500,000 people plus in our jails in custody, 35,000 beds for psychiatric care in the community. That's forensic and civil commitments. So that means that when somebody's in crisis, where are they going to end up? They're going to end up in one of 3 places. They're going to end up at a hospital, ER. They're going to end up in a jail, or they're going to end up deceased because of that interaction. So this is a very serious thing, right? We're overpopulated in jails and prisons already. And so this is a dire consequence. And this county, Bexar County, is having a lot of initiatives that they are working on to increase bed capacity at the state hospital, to increase other opportunities to divert people into a subacute treatment facility instead of being in jail, instead of being in the hospital. There are 10 times more people diagnosed with mental illness in jails than there are in the community. So if you think about, I think Judge Heff had a percentage out that said that it was somewhere about 30% mental illness over COVID. We have upwards of 50% even before COVID that were in the jails. And now we're probably looking at 60 to 70. And those are diagnosed. How many are undiagnosed? How many of them have a diagnosis and do not want treatment? Obviously, it's a strain to our system. Our detention officers are not equipped for that, just like our teachers are not equipped for all they have to handle in their classrooms now. Detention officers are meant to secure people, right? They're not equipped to have, out of their unit, 60 of the 80 people have a mental illness. That's a lot for them to manage. Nor is my team equipped. We've increased our staff at a time when there was a huge staffing shortage across the country to try to help offset this. And so it's a huge strain, right? And it's a strain for you as the taxpayers. So just so you have an idea of what we're talking about, SASH, which is our local state hospital, has both forensic bed capacity and civil community capacity. They have just over 200 beds online. The current population of the jail as of Monday was about 4,300. Remember, 60% mental illness. On my specialized housing units, my specialized ones, acutely psychotic, suicidal, have serious mental illness and have difficulty functioning in population, over 500 people. So we're already more than double what the state hospital can have. And unfortunately, they have a lot of protections, right? Everybody maintains their civil rights in there. They can refuse treatment. So I can have some very, very sick people who do not want to receive medications even though they're offered, who are staying in our jails. So in some sense, they're more sick than if they're at the state hospital, right? So that's more than double. So our most common mental illnesses that we have, that we see coming through, all of these are much higher percentages than community percentages would be, are the schizophrenia and schizophreniform diagnoses, bipolar disorders, mood disorders, anxiety, PTSD is really coming up on there. And about 65 to 70% of our folks have a complex trauma history. They have either been a victim to, a witness to, or participated in acts of violence and traumatic events. More than half of them will have substance-related conditions. So it's really important that we identify folks at the earliest point possible so that we can get them into the treatment with our providers when they come in. So what I'd like to do is just kind of walk you through how some of that happens. I want you to imagine that you are being arrested. I don't want you to do that, but I want you to imagine that you are a free person in the world. You, for some reason, weren't thinking, made a bad choice, whatever, you end up having the bracelets put on you. That in and of itself, you've been pulled over for a ticket, that in and of itself makes your heart do a lot of this, right? High anxiety, high stress, and going through your head are things what about my job? What about my family? Who's gonna take care of my kids? You know, maybe I'm on some kind of medication. What happens if I don't get my medications? I got this condition. You're worried. It's all consuming. High stress, right? So we want to identify these early. It starts on the streets with our law enforcement. Their training has upped up so they can identify folks with mental illness, intellectual disabilities, other kinds of physical disabilities, where it is going to get in the way of why they were even involved with them in the first place. Somebody's calling for help for some reason, and their training is being increased so they can identify when is that really a crime and when is it somebody who needs to get help. And they are able to divert them directly from the streets on an emergency detention to a hospital. It continues with every interaction that individual is going to have as they come through our booking process, as they come into our facility, as they get admitted, and as they get housed, and every single contact they have with our staff every day throughout their incarceration. And if they're on one of our units, on the way out the door as well. So during the arrest, and the earlier presentation alluded to this, there are 4 or 5 questions that the arresting officers ask. And I will say that when this was developed, it was way before Sandra Bland law, way before a lot of those other things. It came about because we saw the need that we need to know more and try to get people not coming into the criminal justice system, but getting into the mental health care system. So the arresting officers are asking the individual, family members, or whoever else is involved with that arrest when they're in contact with that person, do you know if this person has a mental illness? If so, what is it? Do they take medications? If so, what is it? Have they ever been hospitalized for mental health conditions? Do they have a history of a suicide attempt? Are they currently feeling suicidal, or are they engaging in some kind of self-injurious behavior? Key questions. Key questions. These questions trigger a whole lot of things that happen when they hit the front door at the booking area. The Center for Healthcare Services have clinicians down in that booking area, and if that person is in crisis, they go out to the arresting officer to get more information, and they interview that patient right there and then. If they are in crisis and it is something that they can approach the judge to divert out, so they have a minor offense like a criminal trespassing, theft, DWI, lower offenses, then they can approach the judge, and the public defender's office is down there now, magistrate is on site, and that judge can grant a PR bond to that person, and they can go either on an emergency detention if they're truly in crisis out to one of our emergency centers in the hospitals, or if they're pretty stable but they need treatment, they can get a PR bond directly into treatment, not come into jail at all. The other thing that happens is that by state law, every person that is arrested is required to have a series of questions asked by the sheriff's office as part of their booking. That is called the screening form for suicide and mental health and intellectual disability form. Big old long name that means we're going to ask you a battery of questions about your medical condition histories, medications, hospitalizations, substance use, suicide risk, special education, learning disabilities, and where any of those things, or if the officer picks up that maybe you're hallucinating, you're disoriented, you're not on task, your thoughts are all over the place, you're just rambling on, you're aggressive, you refuse to cooperate. They can write all of that on this form. This form, along with something called the Texas Law Enforcement Tracking System Continuity of Care Query, another long name. We lovingly call it CCQ because it's too long otherwise. This runs a database of the person's name, date of birth, and social security number against the state's database. And anybody who has been in contact with a mental health agency anywhere in the state of Texas, if it's a positive match on that or even a probable match on that, those two things trigger further assessments in our facility. Okay? This is where the 1622 that D.A. Unkelfer was talking about earlier comes into place. So these two forms are yeses. They get their criminal history. Maybe the 4 questions were yeses or possibles. All of that goes to the magistrate judge. That judge can order a more intensive evaluation for that person at that time. That report gets sent back from the mental health clinician, is available to the prosecuting attorney, the defense attorney, and the judge that's going to be assigned to the case. So they have more information to assist their clients. Also over there, you have the judge magistrate in the center, the public defenders, the CHCS clinicians, and the whole intent is to try to divert folks out of jail who don't need to be in there, to not criminalize the mentally ill. Now, we're going to go into what our team does. That's all front door. They haven't even gotten past booking yet. They've been fingerprinted, had their picture taken, saw the judge, had a bunch of questions asked of them at the front door. They barely have sat down in the booking area. Okay? In that booking area, I also have my medical staff is there. We have nurses, RN nurses, LVN nurses, that are doing medical intake screenings on every person coming into the facility. That is a more detailed input of their medical history, chronic care conditions, if they have any injuries. It also includes a psychiatric screen. It also includes a suicide screen. It includes substance use screen, learning disability screen. They will refer to us anybody that has a yes on any of those. And it's not only what they're saying, we have the privilege of being part of our whole hospital system. We're part of University Health, so we have access to our hospital records. Our hospital records are also linked over to some other hospitals. So if that person has a history anywhere in that network, our staff can see it, which is very helpful when people don't really want to tell you what's going on, right? So our seriously mentally ill, who, especially the ones that come in a few times, many times, how many times was it? 30? Right? They come in a lot. They're going to say no to everything on all of that. They're going to say no to the nurses. We're still going to know, hey, guess who's coming back in? Look, make sure we get that screening done on them when they walk in the door and get them on our unit. Because we know these guys, because we're there and we have access to it. So at the front door where the nurses are, if that person is prescribed medications, let's say they're on Zoloft or Risperdal or whatever out in the community, our nurses have the ability to access a particular kind of software system that if that person can tell you where they got their meds filled, they go to H-E-B pharmacy on wherever, they can see that that's a true medication, they can tell the diagnosis, and they can tell when it was last filled. Those medications can then be started at the front door because we've confirmed that those are true medications. For somebody who says, I'm on meds, but I don't know what they are, which unfortunately happens more often than you'd think, then we generally will still start them on medications at the front door. It may not be what they're on until we can verify what it is, but we'll try to get something started so they don't decompensate on us, right? Detox meds ordered, all of that. For those who have not been in treatment, have not been on meds, they're going to have to wait until a provider actually can see them in order to get medications prescribed so they can do a review of what their psychiatric symptoms are. Okay, we get referrals from the judges, we get referrals from CHCS, those clinicians down in that facility. Every shift we're getting a report from both of the clinicians that are down there, every shift that they're on duty. They're 24/7, we're 24/7. Anybody that's a positive that they screened over there, we're going to try to catch on our side for further assessment. Family members, defense and prosecuting attorneys, the defendants themselves, of course, the majority of the referrals come from our own nursing staff. So when they come over into the jail, now they haven't bonded out, nobody's posted their bond, they didn't get a PR bond, they're coming over, they're going to stay with us for a while. They're going to have their screening, their further mental health screening done by my staff. My staff, can you wave? I have some of my people here. They're right in the middle, looking like, hey, why are you outing us? My staff is 24/7. I have 32 people that work under me. There's social workers of variety of levels, clinical social workers, master social workers. I have a couple of LPCs. We're a variety of folks in there. And And we're on both sides of our campus. We have two different buildings. We have a huge building where there's 3,200 people, and then we have an annex facility where there's about 1,500 at times. So they're on both sides of the house. They're doing these intake assessments among a bunch of other stuff that they're doing. This intake assessment is a much more detailed, specific to psychiatric care for the folks coming in. So we're going to be asking them, hey, what is your history of hospitalization? Which hospitals were you at? When was it? What was it for? Have you been to inpatient treatment for psych? Have you been to outpatient treatment for psych? If you're an outpatient, do you have a provider now? If so, who is it? What's your diagnosis? What are your medications? We're going to go down the rabbit hole a little bit with them and get as much information as we can from them so that when they do get referred over to our psych team, they have the background that they need to do that. We're also going to be asking them more about their history of substance use. So what kind of substances have you used ever in your life? What are you using now? When was the last time you used? How much are you using? Do you snort? Do you shoot? We're going down a lot more detail. And sometimes my staff is catching things that they didn't report to our intake nurses. And that's where it becomes really important that our folks, work with our medical team and say, hey, this guy needs another review because he's telling us that he's coming off of heroin, he's coming off of alcohol, he's coming off of whatever. And he didn't report that when he came in. We're also looking at if they might have an intellectual disability, if they might have a cognitive disorder like dementia. We're talking to them about their suicide risk level, if they've ever had an attempt, when the last time was, by what method, what was going on in their world at that time, and if they're thinking about suicide now, and if they have a plan. All of that information is going to be used to determine what level of housing management do they need? Do they need a referral over to our psychiatry team? Do they need a referral to our medical team? And if they have situations where they could be in crisis and they have a lower offense that didn't get PR bonded out, then after a few days, if they still haven't settled down, I'm going to be calling my friend Sally over there, and we're going to be talking about other pathways of trying to get that person out of the jail for their safety. So services that we provide in there besides that general intake screening. We do have psychiatric evaluations go on. I have full-time psychiatrists there. I have mid-level psychiatric providers. We do medication management with folks. I have 1,200 people on psychotropic medications today. 1,200 out of the 45. There's probably 300 or 400 more that should be on that don't want meds. We do case management. We do crisis intervention. This is day in, day out work for my staff. Individual counseling, we have a few mental health groups that we facilitate for the jail. We run a women's trauma recovery program. We also run an addiction recovery program for the jail called RIM, Recovery in Motion. They've been going on for a number of years, have had great success. Some of the participants are court ordered by Esperanza Court or the drug court, but most of them are voluntary. They want to get better. They want to be in treatment. And these are all evidence-based programming that's being done. So we'll do advocacy as well. So we might reach out to their attorneys and say, hey, you have somebody in here that we think might have some mental health stuff going on. You might want to talk to your person and see kind of if they need some other assistance. We also will advocate with detention with the officers because remember their whole mission is safety and security. Ours is recovery and treatment. And so sometimes those mindsets do not match, right? So if somebody's having a struggle, we try to work with our detention officers, do some education with them, and advise the jail on what would be a safe setting for that person to be in, especially if they're having some trouble. And then we coordinate release planning. So when somebody's getting ready to leave us, if they're going back into a community setting, whether it's to a treatment program or if it's back home, then we want to work with whoever their support system is or is going to be to help them navigate connection over to services for treatment so they can get an appointment on the outside, making sure they have some way to get home if nobody can pick them up, making sure that if they have a place to go, that they can get there. If they don't have a place to go, to see if we can refer them to one of our temporary housing settings. So we're trying to get as much provision to them, and of course, all of it is voluntary, right? We can give them the linkages, we can set them up, but they gotta go do it, right? And then for those folks, of course, who are not safe to release, we are going to emergency detain them to a hospital so that they can be safe in the community. Or we're going to send them out an order of protective custody, a civil commitment to one of our other beds out there, if we can get a bed available. So just a little bit about our specialized housing. We do have acute units for both men and women. And when I say acute, I mean that these folks they're having active psychosis going on, even if they're medicated. So their symptoms are very intrusive. They may not listen to officers' instructions very much. They may go into other people's property or invade their personal space, or are so distracted that they just want to leave and they try to run off their housing unit. All of those things will get them in crosshairs with detention, and we're trying to avoid people from getting hurt, right? So we will put them on our acute units, and we will try to work with some medication management, try to work with some skill development to try to get them more stable so they can go down to our step-down units. Our step-down units are smaller units where they're in group settings. They're either 24 people on one side of a unit where they're in groups of 4 or 8 in a cell instead of single cells, or they're in an open dormitory of about 45 people. The general housing over there is about 80. So they're smaller units. Anybody that's on these units have assigned caseworkers from my team that meet with them regularly to work on making sure that they are progressing in their treatment plan, making sure that they are taking their medications, making sure that they haven't missed appointments with their providers, making sure they haven't gotten in trouble with detention. You know, they're kind of tracking them throughout their time and trying to work with other things. So if you're a family member, you may get a call from one of my staff members if there's a release signed by your child, of course, or loved one, and they may say, hey, you know, I'm just wanting to give you an update on what's going on because they asked me to reach out to you. Likewise, you could call in and ask the same questions too. And as long as there's a release, we can share information. We also have a suicide prevention unit. On any given day in the jail, we have 100 people on suicide watch. 100. And that number went up a lot throughout COVID. And these are the ones that we identify, right? The ones that don't want to say anything are the ones that we worry about. Our discharge planning, our release planning looks like a coordination of services for a variety of things, right? Discharge plans, release meds, housing, clothing, food, employment, how to contact Social Security. Aida, are you in here? She just left? Okay, bye, Aida. We'll refer them over to Aida at reentry. We'll refer them to Social Security so they can get their Social Security stuff either reinstated or started. And then, of course, the transportation sets. Now, if you have somebody in jail that has a mental illness, I need to ask you to do a few things. Tell the arresting officer is the first thing. Say something. Because you know they sometimes don't want to say anything. Reach out to their assigned legal counsel. They are your first contact in the criminal justice system, right? Let their attorney know that your loved one suffers from mental illness and whatever all else has been going on with them. You can also call my staff. These are the 2 phone numbers. For the men, that's our main line, 335-6271. And if it's a lady, then they're mostly housed at our annex. And so if you call 335-6875, that's the line into the mental health office over there, okay? Any of my staff will take your information. They're going to tell you, I can't share anything with you because I don't have a release, the HIPAA law. Give them the information you need. I know you can't share anything with me, but I need to let you know that John has this, this, and this. He takes this medication. He had it last this. He's been doing X, Y, or Z out there, and we're afraid. We need him to see somebody. Tell us information. What we'll do with that, if we haven't identified him already, we're going to go make contact with them and do an assessment. And they can deny every day of the week, whatever they want. But you're asking for a welfare check, essentially, right? My loved one has this issue going on. Can you please check on them and have them see somebody? And so we'll get a referral over to psychiatry to get them seen. If you have documentation, collateral, that says this is their diagnosis, this is their medication list and dosages, that would be wonderful to have. So you can fax it over to us, you can email it to me, whatever you want, I don't care. But having that information, what I do with that is it gets scanned into their medical record. It also gets given to the provider that's going to do their evaluation, so they have it in hand. Helpful tips. Yes, UH provides medications while in custody. We do provide treatment. Please do not bring medications to the jail. What happens when you bring medications to the jail is they get put in their property. It's not helpful, right? We provide the medications. It's important that we know what those medications are, and we'll take it from there for you. We do have a limited medical formulary, so the providers may not be able to order a medication that's newer on the market, but they'll work on something equivalent. And they'll talk to the patient about what those options are, and they'll agree with whatever that might be. We do follow all federal and state laws about privacy. Folks who are incarcerated, whether it's in jail, prisons, ICE hold, juvenile detentions, they have more protections and rights than you or I in the community. More protections. And so we have to follow the privacy laws. No option about it. So unless they have signed off on a release that we can tell you, in particular, whatever's going on with them, then you're probably not going to get a whole lot of information, right? Because we have to protect that. Now, we could always go and get a release, so we can try, but they also have the right to refuse to sign that. Medical and mental health treatment is all voluntary. The only time my staff can force treatment is if a judge orders it. So sometimes I'll get phone calls in my office from very frantic parents, and rightly so, that they've been having somebody who's been very erratic at home. They need them to get help. They're not taking their medications. I called the police because the police officer came and told me, send them to jail and they'll get treated. We'll offer treatment, but we can't make them. If they're not taking them on the outside, they may not take them on the inside either. Right? We can't force them. That's their right. Just like they don't have to take their diabetes medication. This is my contact information and the numbers for our facility again. My phone number in my office is 335-6414. If I'm not there, leave a message, because I'm in and out all the day. Okay. But I'll get back to you. Everybody take their picture? I see all these cameras. Okay. So what I'd like to do, that's our basic services. We have a lot of things going on, throughout the day there. I do want to segue into what competency looks like as you go through the jail process here. I know Sally and Judge Huff talked about what happens when somebody's found incompetent and what that means. So we're going to echo that a little bit, and then I'm going to talk about some variety of things going on and segue into Annie's new endeavor she's got going. So competency to stand trial is a legal requirement that a defendant must be able to understand and participate in the criminal proceedings against him or her. Are you able to help your attorney in their defense and understand what's going on in court and the roles of everybody in there and the ramifications? Are you able to understand what happens if you're convicted or given probation? You know, if there's questions about that, or if the person is not really thinking clearly and the attorney's like, I don't know if this person's going to be able to manage this, then they're going to ask for what's called a competency evaluation. And then this process starts. Right? It's based on the principle of due process. You can't do due process unless somebody has the understanding of what that process is. It can be affected by both mental health and physical health disorders or impairments or intellectual disability, things like dementia. We have a growing number of people that are older in our facility. If the defendant is found incompetent, then all of their criminal cases are postponed. They're kind of just put on hold until this competency is addressed. They don't go away, they're postponed. If the person is found incompetent to stand trial, they must go to specialized programming in the community or inpatient in order to regain custody, competency. The judge may order them to one of three things. Inpatient, which would mean that they have to go to one of the forensic hospitals. San Antonio State Hospital, Vernon, Rusk, Kerrville, one of the state hospitals that are out there. They can be ordered to outpatient. Outpatient means that they are able to be released to the community and they're going to receive their competency restoration treatment services by an agency outside, and they can live at home or wherever else. They got to go to classes, do their medications, all that kind of stuff. And a brand new thing that we just got rolling is something that the CHCS team is partnering with the county and us with, is jail-based competency restoration. So the wait for the state hospitals are super long, right? Anywhere from 10 to 15 months just to go to SASH on the lower offenses, and well over 2 years if you have a felony offense that's aggravated. Well over 2 years. And that's after you're found incompetent. So the state allowed, I guess it was maybe 4 years ago, for a pilot program on jail-based to start in Houston. And basically what that does is it plucks out the competency program from the state hospital and puts it housed in the jail itself. So folks stay in custody at jail, but they go to programming during the day and work on their competency restoration there. They restore to competency within the period of time that was set by the court, then they are able to restore and move forward with their case, and then it's resolved without having to wait to transfer out to the state hospital system. So with that said, I'm going to let Annie take over.
Thank you. I get to stretch a little bit. Okay. So, some more numbers for you guys, just to kind of get an idea of what we're looking at here in just Bexar County alone. So, in the Bexar County Adult Detention Center, there's currently roughly about 300 individuals that are in jail that are incompetent to stand trial. And so this means that they're just in jail. Some of them may be receiving some mental health services in the form of medication treatment, but they're not getting restoration services yet. So they're pretty much just there waiting to get time out on their charge, not going anywhere. So you can imagine the strain on the limited county resources that this has, because it's, an annual cost of $25 million to house these individuals. Across the state of Texas, there's more than 2,500 people currently on a wait list for a forensic bed in order to receive the restoration services. So we know Ms. Denise had already kind of touched on that a little bit. And so roughly 70% of the state hospital beds in Texas are currently utilized by a forensic population.
So in December 21, the Center for Healthcare Services did receive a federal grant award by the Department of Justice to be able to launch the first jail-based competency restoration program here in Bexar County. Woo-hoo. So huge accomplishment. And so there was a lot of, multiple planning phases to implement this program, a lot of onboarding of staff, training staff, creating process flows, securing space within the jail, collaborating with the county and UH on various MOUs, of course, going through commissioner's court, all that good stuff, so that we are now able to serve at this time, looking to serve at least 40 individuals for the year 2023, and then for next year, we plan to double that. So as I mentioned, some of the partners that we have collaborated with, of course, is the Bexar County Mental Health Department, the Bexar County Sheriff's Office, and University Health within the jail. So obviously, aside from this being the first JBCR in Bexar County, just some of the benefits of being able to offer these restoration services to inmates that are residing in jail is to be able to give them access to those restoration services so they're able to hopefully restore to competency and then stand trial to resolve their charges. It provides a very cost-effective alternative to be able to reduce the demand for inpatient competency restoration. So instead of having to sit and wait for a bed, they're able to, hopefully get restored to competency while they're in jail, so that's also reducing that wait list. And of course, it's going to minimize the stress of the incarceration for the offender. It's going to help to preserve their civil rights, get them to due process. When you're suffering with mental illness, being in jail is no place for you. We want to help these individuals to be able to get restored so they can get out of that environment. So the way our referrals are currently working, every week, we receive a list of individuals that have been found incompetent to stand trial. It's called the clearinghouse list. This is a list that is generated by the state. So we receive this, we filter it, and that's kind of what we go by right now as we're piloting this program to be able to hone in on individuals that have been waiting the longest currently in jail for the restoration services so that we can work with the courts to coordinate to get them screened, to try to get them into our program. And then, of course, there's times that the court will, request if we can look at somebody for the new program as well. So that's another referral source that we're utilizing. So a little bit has already kind of been shared with you guys. To be eligible for jail-based competency restoration, of course, you have to have been found incompetent to stand trial. You're not able to get bonded out into the community, and that results in needing to have the restoration services in the jail. Do generally have to have a mental health diagnosis, but most importantly, and I do emphasize this, and I know Denise kind of touched on this a little bit too, they do have to be willing to participate. We do screen some individuals that have been on the wait list for a while, but they refuse the services, and so those are people that we will always look to try and revisit later on. But there's that old saying in Texas, I think it's in Texas, you can lead a horse to the water, but you can't make him drink. So, we definitely have to have folks willing to participate in the program so that they can benefit from those services. So when we do get somebody that is willing to participate, we will coordinate with the court to request a letter for permission to screen. So for us to be able to even screen somebody, we do have to have permission from the court and pretty much from the attorney, rather. So if we are going on the clearinghouse list, the center will submit a letter to the court requesting permission to screen, and we will obtain the defense attorney's permission to screen form during that process. If the court requests somebody to be screened and maybe they've been on that list for a while and so we're like, yeah, let's go ahead and try to get them screened, usually we'll obtain that letter from them so that we just have all of our documentation. And then of course, we get copies of the competency evaluation that had previously found them incompetent. We look at the police reports, we look at any previous history. Our team is very active with Miss Denise and her team. They communicate daily to be able to kind of coordinate getting to know these individuals that we're looking at coming into the program. One of the things that is not mentioned on here that is noteworthy is because we are providing these services in the jail system, there is what they call a classification system. And this is what determines what inmates can actually be in the same room together. And so that is something that we're having to learn how to kind of work within. Right now we have 10 individuals, 7 that are active, in our program and looking at doing additional modification next week with some more folks. But that classification status does govern how we're able to even have these individuals on the floor that we work in. So that's something that we're currently learning as we're piloting this program. And so if somebody is clinically appropriate, that means, their symptoms are pretty stable, they're able to communicate, we can work with them, we think that they're gonna be able to, absorb the curriculum. At that time, we submit the letter to the court, we request a hearing for the modification, and then that person begins receiving those services. So we actually complete an intake enrollment there in the jail. Our team actually meets with those individuals and completes their enrollment to begin providing those services. And like I said, if they're not clinically appropriate or they're not willing to participate, we kind of keep them on a side list so that we can revisit them later. Maybe, if they're able to, get more stable on medication, maybe then they'll be willing to want to participate or be able to kind of absorb that curriculum that we're trying to help them with. So I know the center, we're the local mental health authority, so we have a lot of, facilities. You guys may have seen signs when you're out there in the community. So I wanted to be sure to include this. We're not located at the Restoration Center. We are Restoration Services, but this is jail-based. So we are actually in the jail. We're on the 4th floor at 200 North Comal. It is a lockdown facility. And they call it the South Tower, is what we're in. And so the county, was very generous to be able to provide us an entire floor. We have 3 offices with 2 multi-purpose group rooms where we are able to provide the services for this program. The current, staff that we've been able to obtain for the program is a behavioral health supervisor. Her name is Nicole Botomahio. I'm just going to give her a shout out. She wasn't able to make it today, but she's done amazing work so far with helping us pilot this program. We have a court liaison. That's the person that attends the modification hearings regularly, assists with all those, court collaborations and documentations that help people to be able to process into the program. There are 2 senior care managers. So these are individuals, a lot of, I believe they're LPC associates. So they are clinicians with a master's level degree education that provide the curriculum services for the restoration. We are coordinating, with UH to have a registered nurse that is also assisting these individuals, and our own psychiatrists and psychologists. So we actually have our own psychiatrist that is doing telemed, ongoing psychotropic medication treatment for them while they're in our program. The psychologist is who we utilize for competency evaluations as they, kind of move along. So, okay, good, they did come out color. So, one thing that we do a little differently from some of the other JBCRs that we've been able to tour here in our awesome state of Texas is we have the blessing, I call it a blessing, to be able to have our restoration services outside of the tier. We've seen a lot of JBCR programs take place where all of the participants are living in the same tier, and so they just stay in that area and receive those restoration services. But we've been fortunate enough to be able to have our own area where we're able to take them away from that for a little bit, trying to create what we can, as much of a therapeutic environment as we can within the jail to kind of, again, take them away from that setting a little. So the state actually just came out with a new restoration curriculum. It's just called the Texas State Hospital Competency Restoration Curriculum. And it's actually the restoration curriculum that's being utilized for both inpatient and outpatient right now. So that is the curriculum that we are now using. We were previously using the comp kit, which is what Harris County utilizes, but now all JBCRs and outpatient competency restoration services are now pivoting over to this new curriculum. Basically what it is it's a compilation of materials. There's activities, there's lessons that are designed to help provide these individuals with a rational and factual information, just like the basic information about the court proceedings and how to be able to effectively communicate with their attorneys. And we provide these services in a mix. So we have groups and also individual one-on-one setting. And so we try to be very interactive. We've learned from a lot of other JBCRs where we have things like Restoration Jeopardy, and flashcards, and sometimes they'll even watch movies or mock trials and things like that. So it's not just all paper. A lot of it is also very interactive and even like role playing. This is some of the topics that are in the new curriculum. My favorite one is the Courtroom Behavior. That's where they start to watch movies like My Cousin Vinny. And they really like that, but it kind of helps to kind of really give like some good visuals. And so they try to make it very interactive so that it can really, impact. So aside from just the restoration services, like I mentioned, we're also providing the ongoing medication treatment to help them maintain their, mental health stabilization. But we also, the center, in our outpatient services, we use the illness management and recovery curriculum. It's called the IMR. And so during the one-on-ones in this program, we are also offering that curriculum, so that we're teaching them ways to continue to manage their, mental health symptoms that maybe have become challenging. So that, if they're restored or whatever happens after they leave the program, we're trying to, even in this time of piloting the program, teaching them ways to be able to continue to maintain as they move forward. Because some of these folks are going to restore, stand trial, and possibly get released from jail. Some of them may stand trial and get sentenced to, ongoing time, but wherever they go from there, at least they're also learning some ways to be able to continue to manage their mental health symptoms. And so as they kind of make their way through the program, when they get to the end of the curriculum, sometimes if they get to, a certain part of the curriculum where we kind of feel like, I think they may be, we're showing signs of maybe they are restored, we then will coordinate with our psychologists that we contract with to be able to have them evaluated to see if they have been restored to competency. If they're restored to competency, we notify the court. A hearing is scheduled for processing forward so that they can then, resolve their charges, or they move forward. Another possibility is maybe they come back incompetent but likely to be restored. In that case, we would notify the court and we would request an extension. Currently with our JBCR program, for individuals that are on a misdemeanor, when they receive that first court commitment into the program, it's a 60-day commitment. For felony, it's an automatic 120-day. So we are able to request an extension if we feel like they're not restored yet, like maybe they're at the end of this commitment. If we had a little bit more time, maybe we could restore them, so we can request to do an extended commitment to try and, continue towards that restoration. Another possibility is that they are non-restorable. They may come back to where we get told by the psychologist that I don't think this person's going to be able to be restored. And so in that case, we notify the court and also coordinate with our ADA to be able to look at options. What can we do for this person because they're not going to be able to be restored. Oh, here we go. So this is the general email that we have created specifically for the jail-based competency restoration program. You can definitely feel free to email it at any time. Unfortunately, we do have some landlines in there, but this would be the best way to contact us if you had questions about the jail-based competency restoration program. And then I wanted to just also include on there the number for our general, information about the Center for Healthcare Services. We're the local mental health authority, so we provide adult behavioral health services, children's services. We just have an array of services out there for individuals who are needing that treatment. And so this is a number that you guys can reach out to get more information. Okay. All right, so that's all I have for that. Thank you.
Thank you so much for being here with us today. We are here right at 3:30. Please contact Annie and her team and Denise and her team via email or phone. And please join us for our closing celebration. We're very happy that you're here today.
I was okay with that because